Good morning, everyone, and welcome to our program today. This is the second in our Lunch and Learn series on topics related to health, wellness, and hospital librarianship. Today we have Reid Plimpton from the Northeast Telehealth Resource Center. And now I will introduce Reid Plimpton. He is the program manager for the federally funded HRSA FORHP Northeast Telehealth Resource Center, a member of the National Consortium of Telehealth Resource Centers, and this covers New York State as well. While assisting on organizations in developing, implementing, and expanding telehealth programs, he researches and tracks telehealth reimbursement policies, regulatory issues, model programs, telehealth technology, and other topics. Reid completed his Master of Public Health and Honors from the Dartmouth Institute for Health Policy and Clinical Practice in June of 2019. And now I will turn it over to Reid.
Thanks, Christine. Yeah, and thank you all for taking time out of your day. I'm really excited for this presentation and this conversation. I do want to just confirm you guys can see my slides. It looks like it. Okay, so yes. I will say I'm going to be brief in some spots. There are far too many slides. That's the other thing I'll say here, and that's intentionally so. I really was hoping to have some time to hear from you guys as to what you're all thinking and, dive into what's top of mind, but I also aimed to provide you with a plethora of, further learning opportunities as you get more acclimated with the space. And so like, with that in mind, the first thing, I usually start with is just some housekeeping info. As Christine mentioned, the session's being recorded. And she'll make sure that you guys have both the slides and the access to the recording. That being said, this is your time too. And I am very much a conversational presenter. I would rather you raise your hand, ask your question in the chat, unmute and interrupt me, whatever it is, and then wait till the end so that we can talk about the questions when they're, top of mind, rather than when they're 30 slides past and everybody's sort of thinking about other stuff. And then, as Christine alluded to, as part of our job, if you have questions, please do not hesitate to reach out to either my entire team at this email here. You'll get a hold of all of us, or you'll see my email in the back half. It is quite literally what we're funded for. And so I'll move into that briefly, just trying to make sure that you guys are aware of the telehealth resource centers. Explaining my resource center first, the Northeast Telehealth Resource Center is, I joke, we have two parent organizations. Myself and a lot of our staff are housed within MCV Global Health, which is a global nonprofit public health institute. And then we have some folks housed within both the larger University of Vermont Health Network and their academic medical center itself. All of us, the entire NCTRC is NETRIC rather, is thrilled to be a part of the NCTRC. And before I move on the slide, the last thing I want to say, is I need to, is A, I have no conflicts of interest for you guys to be aware of. But B, I am not a lawyer, and this is not legal advice. That is something that is true of all TRCs. We are just trying to provide folks with the best information and resources to go talk to their risk and compliance officers and whoever else they need to that can provide legal advice. Anyways, there are 14 of us across the nation. So the government funds 12 of us to divide up the map. And so myself and my team, we cover all of New England and New York. And then you can see, the colors sort of delineate the rest of the TRCs. And so if you guys have friends or colleagues in other regions, make sure they know who their TRC is too. In general, our mission from the government is to increase the understanding and awareness of telehealth. It's intentionally broad to allow us to work with the broadest audience possible, right? With folks like yourself, with medical professionals, with patients, with students, with whoever. If you have a question about how telehealth works, that's what we're here for. I will call out CCHP and TTAC as other resources to you guys. Again, don't ever hesitate to contact Netric and our team. But these two TRCs are nationally focused and topic specific, right? So the rest of us are jack of all trades. CCHP is the Center for Connected Health Policy. Their whole job is to distill Medicare and Medicaid telehealth policy for the rest of us. So if you ever have a policy question, go there. They've probably got your answer by state and nationwide. And then T-Tech, they do a lot of some of the stuff that you and I are going to be talking about today. Technology considerations, right? They're trying to take away the ambiguity of the technology landscape. There's far more differences at play between dermatology cameras than just the price points. And that's some of what they do, right? Like they write white papers reviewing the top 5 most commonly purchased stethoscopes and highlight, software and hardware distinctions that make it more black and white if you're trying to make those decisions. I often joke they play with toys all day, but they provide some really great resources for the rest of us in terms of the technology. And I guess I'm going to skip through these slides because I've already kind of covered them. In general, we're here to help. If you have a question, reach out to us. We'll do our best to answer it or go find the information for you. Like a lot of your roles, our job is to be, an information hub and to host events and things like this to continue to push that information out. So that's who I am. That's who we are. I thought after talking to Christine and, I will pause and say that the idea of telehealth access points, which we'll talk about in a little bit, and which libraries would be considered, is a big soapbox of mine. I was pretty thrilled once she brought this idea to me to have this opportunity to talk to you guys. And I spent a lot of time trying to figure out how best to factor this conversation in, because I know some of you are interwoven with academic medical centers, whereas other you are, a more public-facing library or only a public-facing library. And so you have different encounters and experiences with telehealth. Some of you have probably used it as a patient. Some of you probably have not. And so I, as much as it's probably rudimentary for some of you, I wanted to start with this sort of just level set. Let's make sure we all know the exact same terms. And so I tend to think of telehealth as a tool in your toolkit. It's not a new clinical, care avenue. It's more a clinical care avenue is using technology to do what they do. But then, so if you look at it like that, it's like an umbrella, right? So you have terms like telehealth or digital health or telemedicine that sort of are the spoke, the top metal point. And then you take these 5 buckets I've got here, and those are your metal arms that go out, around to give you that sort of structure of what is telehealth and digital health. And then the clinical modalities are like the fabric, right? Like that's how it happens. That's the actual, this is now you're no longer getting water on you. That's like kind of how I've mentally wrapped my head around this over the years. And so I say that because like these are all unique technology modalities that cut across clinical avenues. So when I think of libraries' involvement in telehealth in the future, it's with all of these if the library has the capacity to do so, which means that the clinical care encounters that you might be encountering are also quite broad. Like remote patient monitoring typically, cuts across the chronic care conditions and other biometric-based physiologic data capturing. And so you can see a lot of different populations have remote patient monitoring viability. Obviously, one that makes a lot of sense and is one that is needed in our region is for our aging population, things like blood pressure, diabetes management, things like that. And those can all be either devices that a patient comes and uses at your facility because you have the internet access and you have the space for them, or in some scenarios, maybe even you just have a device at the facility and the patient comes to you, says, hey, my doctor asked me to come use your blood pressure cuff once a week, something like that. And so it is a type of tech that could have a lot of involvement. And that's kind of how I made these buckets. I hope that's clear. Sample software there's a lot here, and that's intentional. I think it's a piece of the puzzle that's probably top of mind for folks like yourselves in the way that you would be intertwined in the system, but it is not always at the forefront of the patient provider encounter scenario. So ensuring that, if you have a telehealth space and the health systems in your area that might use that space for their patients, ensuring you have software for what they need you to have software for is a big piece of the puzzle, right? So that's really my intent here, is to highlight that. To me, it's not safe to say what your providers are going to be using to use the telehealth interaction with their patients. We could all assume it's going to be Zoom or DocsMe or Teams or, GoToMeeting. But there's so many out there that, like, if you have a new relationship, you're blossoming in terms of using your facility. I think one of the first questions would be like, what is the software expectations that we would need to maintain for our constituents, for our community to be able to access you as a provider? And then you get to the equipment. I think a lot of times folks start the other way around. And unfortunately, there is many possibilities of buying hardware that is software specific, right? And so these next couple of slides are just photos to kind of show you guys some of the landscape. And then I do want to pause because I have, including the appendix, I have 80 slides. And I'd like to make sure that the conversation is sort of as useful to you guys as possible. So right here, I'm just sort of demonstrating different video visit delivery modalities, right? And none of these are actually stationary, right? So that's the nice thing about this is you're talking a laptop with peripheral cameras being plugged in through USB. This is actually called the field kit. And I have more examples of these in a few slides. This is something you see at schools or athletic departments or community health worker models, where there's like typically a medical professional coming with this thing. And then this is a cart, which everybody's probably pretty familiar with, but carts come in a lot of different shapes and sizes. And obviously that allows you to not have to commit a piece of your facility permanently to telehealth, and rather be able to, activate, for lack of a better word, any room you have at your facility that's HIPAA compliant, right? If it's got a locking door, if it sounds secure and the patients can schedule it and reserve the time, you roll this card in there. You can use any of your conference rooms in that scenario. So that's just a couple of different examples of the way to deliver video. Stethoscopes are a very common peripheral. I think that depending on the use of these, that you start to see medical professionals with stethoscopes, right? So whether it's community health worker, or a visiting nurse, or a family nurse practitioner or something, like, typically it's not a patient gathered information set unless there's a validation source to that. And I can tell you guys more about that. But so these are pretty common. And there are quite a few different examples of them. I would say that anecdotally, I've heard that the ones that look and feel like real stethoscopes are the ones that providers prefer, as opposed to this pocket one right here. Otoscopes, again, depending on what level of clinical training you have at your facility, this is a very common peripheral. And what I've actually kind of shown here is 3 different major players in this space. The one on the left and the one on the far right. So the one coming out of the camera or the computer, and the one that's a tall white thing, those are multi-function cams, which the middle one is not. I should just clarify that. But what I mean by that is those devices have a male-female receiver right here on the back end of this side, and right here at that little nozzle tip there on that piece. So that they can be an otoscope to go in, ear, nose, mouth. They can be a derm cam to do a dermatology screening. They can do a general camera just to show bruising or swelling or whatever. There's up to, I think, 8 different use cases for each of those models, different cameras you can buy. And that is a good example of, doing your homework, because the Firefly is a great otoscope, but it's only an otoscope, right? So if you had a healthcare facility that was making it so anything pie in the sky is possible, you would also then need to get a derm cam. You'd also then need to get a stethoscope, so on and so forth. Whereas if you look at these 2 on the outside, you're out of the cameras after that, right? You've gotten all the cameras you would need just with those attachments, and it ends up sort of saving you money down the line. So that type of distinction starts to show up here. Again, carts, a lot of different ways to do it. So the photo on the far left is actually quite literally a pole that a hospital installed in their ceiling and their floor. And then they put a bracket hole amount on there, and the tablet sits there. And so they can raise the height, but that thing's not going anywhere. It's a stationary design, but it's still kind of a cart because it has, a stand and everything else. It's less of a table. The ones floating next to it are some of the higher end ones. Those things the reason why there's so many on here is the range is so big. You can get a cart that's $25,000. You can get a cart that's $2,000. you can do what's this photo that I'm breaking down did, which is literally build your own, right? So they took one of their own blood pressure carts and sort of adapted it to fit telehealth. And, it still has the blood pressure stuff right there, but it is much more transportable. Field kits, again, I think are a great example of how you can kind of get everything in one spot, pick the box up, and walk away with it. I will say that these are on the higher end in terms of cost for tech. And there's the differences between them are sort of the bells and whistles, right? So this blue one, actually, you can see it right there, has a charging port. So the field kit itself has a battery pack, whereas like this black one, everything else has to kind of come out and be charged and placed back in there. And so the distinctions here are massive. And, what you include for stethoscopes is also massive. But these are a great example of how you can get everything in kind of a compact way rather than potentially having it, take up a ton of vertical space. Couple more slides before I pause to see what you guys think. I just wanted to look at where I was on the slide deck. So this is less hardware and it's more operations, but I think it's a good example of avenues libraries could play in the healthcare space if the conversations are had with the proper parties, right, with the medical providers and everything else. An asynchronous consult, as you can see here, this is actually a dental screening. The thought process is that the patient gives information and indications, whether it's notes and photos or just photos, to a provider or to somebody intertwined into the provider space. It's going to go into the electronic health record, and then the expert, the specialist, the dentist in this case, would log on at a point down the road. Most of them are doing it same day for billing and reimbursement reasons, but would log on, say you send them the photo at 10, they might log on at 2, look at the photo and give some sort of recommendation. Does this person need immediate care? Can we adjust their medication? So on and so forth, and push that information back through the portal. If it's a fast enough encounter, the patient may still be there with the other person waiting for that information to come back. Otherwise, the patient would get the notification through the patient portal, just like everything else. But it's a pretty easy way to add access to specialists solely just by providing a camera and then an avenue for data transfer. The EHR connection to the health system is the big part there, right? You have to be able to be in their record and or find a way to transfer that photo to their record securely. But that's something that you can ask them and then very easily could do within your space. I hope that makes sense. Like I said, pause for questions a second. But another thing I think I wanted to parse out is the remote patient monitoring versus chronic care management. Because they are both avenues that I think libraries could very easily fit into down the line. But there is very clear reimbursement and policy reasons why healthcare pains themselves to make these differences, even though they're using the same devices and often aren't capturing the same information. Right. So in a remote patient monitoring use case, you're typically talking about monitoring this data for a short period of time. Now, that short period of time could be 6 months, but it's a concrete time. We're not saying we're doing this for the rest of their life. We're saying that, they either just had a procedure done and we need to watch some of their biometrics to make sure that there's nothing, no adverse healing happening, or they've had a recent medical condition that has got them on some new medication, and the provider wants more than just once a week interaction, right? So the patient's going to capture this data 2 to 3 times a day. It's going to transfer to the provider automatically. Provider has a system to say, "Ooh, that's problematic," and escalate it to a visit, or just say, "We're doing fine," and just monitor it, right? That is one where you see a lot of vendor involvement because of the billing. I mean, you see it 20 minutes a month, right? And 3 data points a day, right? Health systems need to sort of have help with analyzing all of that, but it is using the same technology as chronic care management. Chronic care management is when a patient has 2 complex conditions out of a list of 56 chronic conditions that Medicare has divided. I think it's actually 60 now. anyways, out of a large list of chronic conditions, and so this data capturing is now a part of their life healthcare plan, right? Like they are providing this information constantly because they need to. It's like continuous glucose monitoring for diabetics is a good example of a chronic care management use case. But again, it's the same data transfer. So I point this out because as you get more familiar with the health systems and what they're doing, it's hard for me sometimes to fully understand which of these two they are looking at. But the ability they have to support you and or the likelihood that a third party as a vendor is also going to be a part of that data transfer and process differs between these two things. So it's a bit of a complex nuance, but it's something that I think you'll come across pretty quickly. So I wanted to put some stuff in here, and I've linked some in the use case section later. I have linked to some studies that hopefully help make that a little bit clearer. I'm going to pause before I get into digital therapeutics because this is also a kind of complex nuance that I wanted to make sure folks understood so that you weren't confused when people start throwing it out. But I've kind of thrown a few in a row at you. And so did anybody have any questions or thoughts on, how we spend this last half an hour topically? I do want to make sure we cover some of the patient considerations and site room considerations, but we have lots of time here.
So we have a small group, so if anybody has questions, you can unmute and ask rather than use the chat.
I don't have any questions, but I just want to say this is all new to me and it's all very interesting.
Great. Thanks, Matt. I will say that for those of you that are familiar with Project Echo, they used to suggest a 5-second pause to make sure that you were allowing for bandwidth and everything else for people to chime in. And that was always painful for me. They now suggest an 8-second pause, and it is tough to say, but it's important to do that. Okay, so digital therapeutics is a really new term. This is 2022, 2023, but it's like a lot of things with technology being used in multiple different ways, and that's why I wanted to call it out. The broadest sense of digital therapeutics is it's a theory of change model type thing, right? It's how do you use digital technologies to deliver therapy. It could be an app-based encounter. It could be a provider designing their own tech and having their patients use that. It could be, you're seeing video games for some of the cognitive behavioral therapy things for kids. And so it's this whole plethora of things, but it is also by law, by the FDA, a term for delivering medication and treatment through digital means. And so like sleep therapy, eating disorders, and some of the other CBT, cognitive behavioral therapy based theories of change and clinical interactions have this specific digital therapeutic apps for them, such as like sleep.io is one. And I can send you guys a whole list of them, but it is something that is, again, it's just important to feel confident asking the questions when people bring it up, because unfortunately it is a term that's used for more than one thing. And one of the things it's used for is this broad, system perspective of how to intertwine technology. There is a great website for this that I should have linked to right here. It's dtxalliance.org. Let's find out together because I want to show you guys these links. .org. And so they actually will walk you through all the different types of DTX, and they're actually where I've found some of the clinical apps that exist. So that's the whole landscape of tech possibilities. I will say that that's just the broad range of it. I brought some examples of a project I'm working on to show you guys what some of these other tech engagement opportunities, or intertwinement opportunities could look like, that I'm happy to walk you through and tell you a little bit more about. But I did from here, sort of set up a couple of slides of case studies for you to go back to so that you can try to, put yourself in the shoes of being involved in that encounter as a physical space. And so before I do that, part of the reason why we're all here is one of the things I want to call out. You're going to hear me use the term telehealth access points quite a few times over the rest of this session, and hopefully you'll start using it a lot too. It is a new term for an age-old existing thing, which is anchor institutions like yourselves, like YMCAs, like schools, like other community gathering points that are mandated by law to have a certain broadband speed. So they're telehealth access points, right? If a state allows it. And so New York is one of the states that has been progressive enough to allow for the library to be a place of service for certain clinical encounters for patients. So you are, in that scenario, an access point for the telehealth visit for the patient, right? So that's where I want you to sort of think about all these case studies that I'll show you in a few minutes. But it's a term that is gaining steam. I do think there's even a possibility down the line that you see some funding, for sites like this, because digital equity and digital literacy is a huge ball of wax, and we're gonna be stabbing at how to fix it many different ways, right? And telehealth access points are one that is pretty well ready to go. You guys have the capacity infrastructurally for broadband. You have an infrastructural historical process of loaning things out to folks already in place. And you have the community buy-in and perspective of being something they can utilize. It's not something new that health systems have to teach people to go do. Everybody knows you can go to your library, right? And so so you can kind of hit a lot of pain points with a great opportunity of the capacity that you all have. So to that point, the TRCs are doing our best to highlight how many of you are willing to do exactly what you guys are doing here. Learn about telehealth and see how you can serve your communities doing it. We have stood up this telehealth access point intake form to help track all of you guys that have this space. And then what will happen is it will go on to, I should have been more prepared for this, I'm sorry. 2 different maps. Nope, that's my EHR, you don't want that. This one is patient focused, and right now it's currently only turned on for the West Coast, but soon it'll be nationwide. And so a patient can go in here and they can allow their location to be searched. Mine's not going to turn anything up because we don't have any main data on here at the moment. Just pulled it down to do some cleaning. But if I were to put in something in the West Coast, it would have given me any healthcare system that was near me. And it also would have given me a tap, right? My tap, telehealth access point. So if you zoom way out, let's just put in. So now you can see which healthcare facilities around you are offering telehealth services and what their in-person services are that they're offered. You can also see I believe that, the taps are these orange marks. And so this is a library out there in Idaho that I could go to and use their internet, obviously, but I could also tell, let's say this is my provider, Primary Health Garden City. I could tell them, hey, I would like to do my video visit at Ada Community Library. I've already booked a room at the time of our visit, but I need you to send, I will be there and I want you to send the link to them, or I want you to tell me how to access it on my own on their machine, right? So that's the patient perspective of it. And then we're also working through this platform, which will have multiple different perspectives and interweaving taps into this as well, right? So a provider, in theory, down the line can go, I know, here, I'm going to skip some slides to show you what I want to talk about. Could go, I know my patient is pretty high. Their digital literacy is pretty high. They've been using tech most of their life. However, at this current point, they don't have Wi-Fi at their house. They might even have a laptop, but they don't have Wi-Fi at their house. They could say, okay, let me go find a tap on that map and then call you guys and ask if you have a space. And so that's the goal of that intake form, is to get it so that people know you're all out here and that you want to do these things. And so hopefully that's in line with what you're all working on, and you're interested in adding your info to that. So to back up here, I do want to show you guys some of these use cases, really just click through them. So RPM, again, just trying to highlight, that's that short-term physiological monitoring data. Here's two different studies done at university medical centers and the results they got. Here's some tips that, I think from across our years as TRCs, we are hearing over and over again. They sound simple, but when you hear it hundreds of times, that every health system's working through it. And then here's some use cases of ancillary sites being the encounter point, right? So this Eastern Maine Medical Center is actually using the school nurse's office in this scenario, but it could easily be a library if it was lifespan focused, as a way to sort of just decrease, and this is on a couple of slides later, like decrease the amount of time that folks have to take traveling to places, right? Like meet them where they're at, and so if you can do a whole visit in one spot, do it. And they're getting great outcomes. School-based telepsychiatry, again, it is school-based, but I think it's a very easily adaptable one. It is it's a common space that's being providers either going to or beaming into, or both. And then here's actually how that workflow in this school-based telepsychiatry process works. And I think that this slide is probably the most important out of the use cases to me, is because it shows what you can start to look at for conversations with the health systems that you interact with, right? Like if we have a room where I can provide telehealth services, how am I going to find out that it needs to be used? Is it going to be from the patient? Is it possibly from a school district? Is it possibly from the social worker? Will always be from the front office at the hospital? These are things that they can tell you. Like, here's how somebody will come to you to use your space. And you can document that. And maybe down the line, as you get more comfortable, there's the other end too, right? Like somebody could come into you and say, hey, my provider has mentioned that, I should start doing these things. Is this something you could help me do? And you would have a way to say yes and notify the health system that you want to be that. You know what I'm saying? Like the referral process is easily replicable in your scenario. And I think it's an important part to think about. Intake, potentially less so. I've been grappling with this a little bit the last 2 days. I could see a scenario where you as a library have an email address that health systems are sending these invites to, so that it's already on the machine, right? So that like the patient isn't a potential tripping block on the start of the visit. Like, the patient would have to reserve the space with you ahead of time. They'd have to give consent to the health system to send you the invite. But then when they log on to your laptop, your monitor, whatever it is, the Zoom or the Teams call or whatever is going to be right there. And rather than them having to log into their email, open it, so on and so forth. But I could also see, for a lot of reasons, most of the ones I just mentioned, in terms of how that's still a little clunky, that you're not doing intake, and that the patients basically call you, tell you they want the space, and that it is on the patient and the health system to get the visit going. That may be the simplest on the immediate sense. That being said, I think that the back half of this slide deck has a lot of links that you're going to want to print out or adapt in terms of how to walk them through that, because as health systems across the nation will tell you right now, if somebody needs help with tech, that is 10 to 15 minutes that you got to help problem solve. They're not going to necessarily know what their issue is. They just know the video didn't start, and now you need to go there, figure it out, and everything else. And so we've got a number of tips and tool troubleshooting like sheets that I've linked to here in the back that I think would be good to have either, in your front desk where anybody on staff knows to go get it, or even potentially just in the telehealth room. So it's easily accessible to look at. Okay, this is happening, here's some stuff, or, oh, the patient might need this open, things like that. As far as setups, again, I showed you guys tech earlier. It really varies. It depends on the space you have and what you want to commit to it, and then building the best design around that. Value perspectives, that's stuff for you guys to look at later. I often tell people this is your firm your argument slide. This is your like, hey, who are you talking to? Find their value perspective. Go from there. If you're talking to a health plan, unfortunately, like social determinants of health is probably not going to help you as much as like, hey, look at these clinical outcomes, right? And so that type of thought process, that's how you expand your services. That's how you expand the capacity you have. These folks might give you money, they might give you tech or whatever, but not if you're not talking in the right avenue. Considerations, again, I alluded to this theory of change, like thinking through your community, what the barriers are, what the tech you just saw today that could be enhanced, that could enhance your offerings or that you already have that could enhance their lives. And then what is the outcomes that are going to come out of that, both for you and both for the health system that they interact with? And if that's one and the same, that's obviously easier, but for some of you, it's not going to be. And then what's the client level impact? I think that's a part that everybody's thinking about and is very well aware of, but sometimes we don't do good enough job of saying out loud, right? Like they also should know why we think this is so cool. And they also should know why we have this available to them. And it'll help the messaging. So I found family planning actually does a really great job. And so that's why I use family planning here, of walking through how that looks, for them as a system and a thought process. The need, this is again, just helping you strengthen your case as you go meet people. You guys know this. The need for services in our region is immense. And the amount of specialists that we have in the geographic region that we have, none of it jives up. And so the need for sites like you to exist, to allow for us to be able to improve access and improve outcomes is vital, right? And so the benefits and the challenges, again, this is just stuff for you guys to refer back to. Benefits are easy, it. We're eliminating transportation barriers. We're increasing access to expertise through libraries and through medical care. It's reducing costs for gas and everything else. But then there are some challenges that I think are important for folks to either be able to call out or talk through before they go talk to people about getting money for stuff. Or doing new things with the health system, right? Like if you're not willing to acknowledge that you do have to work through a referral process or a scheduling process, then you're probably gonna have a tougher conversation than if you show up saying, here's the stuff that's gonna be tough, and here's the stuff that I know was gonna help. And again, here's your challenges. And I think it's actually, I want to make sure I save time for questions for Christine. I think you guys are already started to solve it. The state of New York has, made some funds available to you. Feds have made some funds available that hopefully trickle down to you down the line. Instead of just being prepared, like if these are your biggest challenges, I think you're in a pretty good spot. And then planning for successes and wins, just highlighting what a nerd I am. Effort impact analyses or matrix, however you want to refer to it, how I make a lot of work-based and personal decisions in my life, right? Like just draw this quadrant out and throw spaghetti at a wall. Would it be high effort, low impact for me to add a cart to this facility, or is that going to be high effort, high impact? Because now we need to know which rooms it can be in at all times. We need to know all staff members know how to work that device. Patients need to be able to schedule that and schedule, like there's things like that where when you start to look through, like, is it a lot of work, but it's going to matter a lot? Is it not a lot of work? It's going to matter a lot. Those types of things. I think it makes a lot easier to find your path forward because there are so many options here, right? And if you can find the high impact, low effort, that's your sweet spot, right? That's things that you can add high impact to your community for that won't turn your hair gray is the goal, right? And so and then how do you know? You identify what you want to measure and how you're going to measure it, and then you start with the end goal in mind, right? So I'm just clicking quick here because I know we're running out of time. But emergency considerations for telehealth. I think it's really important to call out that patients aren't the only ones learning. Providers also have things they need to learn. And so you are likely in that space where they might already be coming to you for literature or other things. Or you may end up in that space where you're going to need to, use this slide deck, use contacting me, do your own research to say, hey, no, we're not the first people to say that we think that, we could do video visits for follow-up rheumatology appointments in our library. It's happening in other states, like that type of thing. We're all still new to it in a grand scheme of things, even though it's been happening for 20 years. It's sort of the reality of policy. Engage end users from the start. I've said that. This slide, pausing on mostly to let you know I intentionally left it phrased the way it was. This is what the providers are dealing with, right? This is what they're trying to work through right now. And so I think the folks that are here on this call today, the folks that are going to watch this recording, you guys are Like healthcare systems are and should be perpetually thankful for you, because you're coming in when they're figuring it out. I think historically, one arm of healthcare figures something out, and then the other arm has to adapt, and then eventually we get to this point of like community level involvement. But it's way down the line. I mean, this is a very real conversation happening across our region right now. Is how do you improve the ability to decide if a patient should get a video visit, right? And so them knowing that you exist and what your capacities are would definitely be a part of this inclusion and exclusion rescheduling considerations. This is, again, spots where they should, that providers are often asking patients these questions to inform whether or not they want to offer telehealth services. And if they know you exist and the answer to any of these are no, it's going to be, okay, contact Christine. Okay, contact Matt, contact so-and-so. Like, here is a spot you can go do this because you clearly don't have what we need to do it at your house. And I still have the ability to let you do it elsewhere. Room design stuff. This is some of the stuff that I think you guys will want to look through and think about. A good example is how fast I talk. Depending on how close the telehealth space you have is to your router, you're going to want to advise people to talk a little bit slower in case there are broadband, difficulties. The teleetiquette is something that I think you've learned through experience if you've done Zoom calls over the last 3 years. Like, you've seen some bad ones. Normally, I'd say I have terrible teleetiquette in my space, but I'm actually mid-move right now, and this is probably the cleanest background I've had if I were to turn off my virtual background in a long time. But thoughts like that, right? Like, if possible, if your conference room has a window in the door, if possible, don't have the camera pointing at that window, because then whoever's on the other side is going to get distracted if people walk by. Things like that. Some of this also gets into HIPAA, though, which is like the locking doors, the identification, verification protocols. And so those are vital things that have to happen, but they fit well within the design of the room. The paperwork is less, that side of this slide is less for you guys and more for the sites you're talking to. Like, depending on what clinical encounter we're talking about, they may actually need to, add your site as a site that has certain privileges in case they're bringing a medical provider, like a community health worker or something else, to your facility. So that side's for them. But the side on the left, that's for you. I think to ensure that you're providing clear communication to the health systems, right? So like one of my good friends and colleagues is the director of Telehealth at University of Vermont. And he does a lot of work with skilled nursing facilities. And he talks about like how, yes, he's working on, mental and behavioral health instances with these patients, but they're elderly. And if one of them falls, he needs to know exactly how far away that is from the help desk. He needs to know what number that is to the help desk, because he's, X amount of distance away in Vermont, and somebody's going to go check on that person. And so those types of things, these are, again, more that you're already going to know. And it's just making sure it's ready to be handed to the health system you're interacting with so that they can work it into their process. Right. Like, so if a person's fallen, his scenario is actually to always call staff, because skilled nursing facility has medical staff on hand. Right. But you as a library may decide, nope, call 911 and tell them they're here, and then call us. And we will make sure that the patient is at the door if they're capable of being moved, or that emergency medical services have clear access to the patient when they get here. But we are not going to interact with them because we're not medical professionals, right? Okay, so I see we have 6 minutes left. I mean, I'm happy to throw my slides back up. I also am happy to let you guys look through them. I will say that a lot of the ones we didn't cover are actually ways to help you look at other things you're doing, like Zoom bombing was a huge issue at the start of COVID, right? And so, and I often remind folks, like, I think Zoom's just the one that got caught. Like, after that started happening, I have 7 video conferencing platforms on my computer. I had to go through all of them and make security changes because they were all just leaving the onus on the individual, right? Like, are you locking your meeting? Are you setting a passcode? So on and so forth. And so that's not the case anymore most of the time. But if you're doing like group community wellness classes and stuff like that, like, there's options. So you can feel more safe doing those visits or doing those video sessions, like cooking classes or whatever it is. And so I have some screenshots of just looking at like how to go through a software for a video conferencing thing and how to make sure it's as secure as you want it. Like, I personally find passcodes make it really hard for people to get on for whatever reason. Sometimes people don't click the right web link that has the passcode hard coded into it. and then ask them for it, and they don't know where it is, then you're 15 minutes late to the session or whatever. So I don't do passcodes, but I do lock my meetings after I know everybody I know. Like if I have 100% attendance, I'm locking that thing down. There's nobody else supposed to be there. And so there's things that you can do like that, that I got some screenshots in here for you guys on, but it's just to be aware of after. Pre-visit considerations, there's some slides on there that I think are really useful for you all to look through, just in terms of like conversational aspects that might happen between you and a community member if you are being a telehealth access point. But also things that, providers may not be giving you for information that you wish you had. That type of thing. Got a couple of videos on that. And then ADA, I have a lot of slides on ADA, both on some new fact sheets that we've done with the North Carolina Department of Health and Human Services for deaf, blind, hard of hearing individuals and using telehealth services, and just on how to go through your own infrastructure and, what you have in-house and assess what you have for ADA compliant or for, assistive tech. I find that a lot of physical spaces like yourself probably just need software, right? They might need a screen reader or something like that if they don't already have it, but you're going to have hardware that's capable of adding those on there. It's not like you're going to have an antiquated, something that can't handle that processing speeds. But it is very intensive in terms of like helping you go through and make sure you have stuff for effective communication, make sure you have stuff for, individuals who, have wheelchairs, so they're going to be able to get to the screen, deaf, blind, hard of hearing, what text size might be useful, things like that. And so those are very clear bulleted slides for you, hopefully all really actionable. And then after that, it really gets down to actually, Christine, if you can turn on, either make me co-host or let me screen share for 1 second. I just have kind of like a high level parting image I want to show everybody. In other countries, my screen, there it is. Okay, my computer froze. In other countries where healthcare payment and policy is not the driver of technological innovation, that's how I'm going to phrase that. This is how they're looking at telehealth, and I think it's really a good sort of wrap up sentiment of what I shared with you guys and what I think you're thinking about, which is like what is technology going to do for future of medicine? And it's a lot. We here in America, with the way that we're using telehealth, are ages and ages and ages away from digital pill boxes and medical drones delivering prescriptions and things like that. But it's not out of the realm of possibility, and there is literature in Europe of it working. So this graph is from Dr. Bertolan Mesko. He's in Germany, and one of the smartest people I've ever listened to talk. But I think it's a good, optimistic, wrap up point. That is like, we're just getting started. It's not just video visits. Someday down the line, there's a chance that like a student could use a library to do a virtual dissection of an animal for their studies, or that a resident could join a surgery from your library visually and watch the, trained surgeon do it without having to drive 5 hours to, upstate SUNY or whichever one they're at. And so I think it's a good parting thought. Like, we're just getting started, and you guys are really well suited to help the health system do it. Here's my contact info down here. You're always welcome to contact my boss. Thank you guys so much for the time. I know I didn't save a ton of time for questions. I brought some in case you guys weren't feeling too talkative. And then in the back, you're going to find quite a few different links and resources and whatnot that hopefully just helps you get prepared and acclimated in the space. And yeah, I know we're at the top of the hour, so thank you, Heidi. And yeah, if everybody else has to go, that's fine. I am game to stay on. If folks do have questions, I'm happy to stay for a few minutes. As long as Christine doesn't have to run, that is.
No, we're good. Any questions?
Nope, thank you. I've got to run too. Very interesting. I look forward to reviewing all of those resources.
Mhm.
Great. Yeah. Awesome. And just, you know how to get a hold of me, Christine, feel free to reach out if there's more questions or if, there's more topics that we can either get you connected to somebody for, or I can come join you. Otherwise, have a great day, everybody.
Thank you.